I wanted to say thanks to our sponsors, the Freighter Hospital Foundation, DINA, the Autonomic Youth Network of America, and the MSA Coalition, who've all been very generous in helping us put this on. Okay, and then what I'm going to cover in this talk is first putting a context. You heard about a lot of things about POTS and passing out this morning, so I'll put a context on this in terms of giving you a bigger picture of autonomic disorders in general. I'll spend very, very little time on peripheral disorders, and then I'll spend a lot of time on Parkinsonian disorders. We will probably not have time to touch on spinal cord, and then I want to spend some time on the end organ management in patients who have structural autonomic disorders. So I'm going to start with a case, and this is a 78-year-old man who's brought to the emergency room for a fall. And if you ask him, was he lightheaded before? Nope, not lightheaded at all. His family says his gait's been slowed and his handwriting's been smaller for the last year. His memory's been failing, and he gets a fairly standard emergency room evaluation, which shows that he has had no infarct and his no bleed, and he looks okay. So he is taking an ACE inhibitor, terazosin for prostatic hypertrophy for 2 years. And on review of systems, he's severely constipated for the last 1 year. And his exam, these are really the salient features on his exam. You get him up to walk him, and he starts to walk, and then he almost falls, he freezes. And if you measure his pressure standing, it's 100/60 when his pressure lying was 180/80, and his heart rate doesn't change at all. So the first question is, which organ systems, so there's 3 questions I'm going to ask. Structural, functional, which organ systems are affected, and is this central or peripheral? So which organ systems are affected? So blood pressure is dropping, right? So vascular system, right? Lower constipation, and prostatic hypertrophy, right, for 2 years. That's kind of unusual to start at this age. So, so maybe the bladder as well. Somebody, you had something else? Brain, right? The brain's affected. That is an organ that we study. Okay, so it's affecting the entire autonomic nervous system. It's affecting the vascular system. It's affecting the bowel and the bladder. But I think the most important point to be made here is if you hadn't been aware of this possibility and hadn't done a review of systems, you would have missed this. So you wouldn't have thought much about the prostatic hypertrophy. If you hadn't measured an orthostatic pressure, you would have missed it. So the standard sort of quick fall evaluation for someone, if you don't do an orthostatic pressure, you're going to miss this. And that's really the important point here, that a review of systems and measuring an orthostatic pressure in every single person who falls is critical. Second, is this a structural or functional disorder? So what do you think? Is it involving, so we'll come back to those definitions in just a second, but is this involving mainly the function of the autonomic nervous system, meaning the structure is okay, or is it eating into the system itself? Structural. It's a structural disorder. It's not a functional disorder. And let me just go into that a little bit. So first of all, how do you tell in your office? Lots of findings, very few symptoms. So we have to get the symptoms from the family. If you saw this patient in your office, the family would be very frustrated because he'd say, I'm just fine. And the family would say, no, you're not. You just fell yesterday. And so it's very hard, as opposed to the younger age group where it's not hard at all to elicit the symptoms, but you may have trouble eliciting the findings. So he denies lightheadedness as typical in structural disorders, and that sort of takes away one critical piece of history that we all depend on, right? We normally depend on lightheadedness to help you know if somebody's orthostatic or not, and that actually doesn't work. And here's a study that we did a little while ago, and we noticed that on the tilt table test, people hardly complained. People who had multiple system atrophy, Parkinson's disease, or diabetes hardly complained of anything when they went up on the tilt table. And so we divided our group into three categories. People that had typical symptoms, is on the left. People that had funny symptoms like toe pain or other kinds of funny symptoms you wouldn't associate with orthostatic hypotension. And people who had no symptoms at all. And we had 200, the numbers are not up, we had 200 patients approximately, and 88 fell into the completely asymptomatic group, so almost half. And if you look at their pressure when they're lying flat, they're about 170 over 80, 90, something like this, and they drop down to 90 over 30, and they're completely asymptomatic at that moment. And we're asking them, are you having any symptoms? So their brain has obviously done something in terms of autoregulation, or they're not aware that they're having symptoms. But don't depend on symptoms in patients who have structural disorders. You can depend on symptoms, very much so, in patients who have functional disorders. So here's a definition. Structural disorder is a disorder in which the autonomic structure is being affected directly, like Sjogren's, multiple system atrophy, diabetic autonomic neuropathy, barrel reflex failure. These are just examples. You could have myelopathy, 1,000 things that directly affect the autonomic nervous system. And a functional disorder is one in which the autonomic function is involved, but it's not so well defined. This is the autonomic nervous system. So in POTS, is the autonomic nervous system actually abnormal? Well, Julian, the world's expert, tells us he doesn't know. And that's the point. In IBS, is the autonomic nervous system actually, irritable bowel syndrome, actually abnormal? So these are what I group as functional disorders. And when I say functional, I don't mean functional as in it's in the person's head at all. I mean functional as in the function of the autonomic nervous system is being affected, but we don't know if there's any problem with the system itself. Okay. Now, so this just is sort of a classification principle between those two. It's very important. I would say probably the most important thing in autonomic disorders in general is being able to separate out these two categories. Is it a structural disorder, which generally has a reasonably poor prognosis, or is it a functional disorder that has a good, at least from a life expectancy perspective, has a good prognosis? So, structural, few complaints, and lots of findings. At least in your mind's eye, you think you know what's going on. There's either stroke or multiple system atrophy. The cardiovascular autonomic reflexes, like deep breathing that you just saw, Valsalva, are all going to be impaired. On tilt table testing, you'll usually see orthostatic hypotension. If you were to measure standing norepinephrine levels, they're probably not being made, so because the system is involved, so they'll be reduced. And I'll come back to the fundamental physiology in just a second. And whereas functional is really just the opposite. So you have an overwhelming number of complaints. If you look really hard and you apply some venous compliance thing, you can find some abnormality. Or if you look at the thoracic impedance, you may find abnormalities. So there are abnormalities. I'm not trying to say there are not abnormalities, but it takes a lot to find them. And you'll usually see a postural tachycardia on the tilt table testing. And frequently, you'll see increased norepinephrine levels, either because you have increased spillover or because the system is trying to compensate for something. So I'm going to put forward to you a little bit of a theory that these two things are not coincidental, but they're actually connected. So there's presumably, so if you've heard of in diabetics, they have hypoglycemia unawareness. We titled our findings as hypotension unawareness. And we think this is actually a fundamental property of the brain, that in functional disorders, some filter has been set wide open, probably in the brain stem, so everything's making it to the cortex. And we were at the table, we were talking about somatization disorder, it used to be called somatization disorder. I don't think they're that far apart because this filter's wide open, so they're really aware of everything. The only thing is I would never say, okay, they're crazy or something. It's not at all that way, but there is a brain phenomenon. And in contrast, in structural disorders, that same set of constructs has now been shut. So they're not allowing important information up to the cortex. So sort of a theory of how to think about these two. And they're really opposites to each other. So these are functional dysautonomias. And you heard a lot about POTS and syncope from Dr. Stewart this morning. And this is just about 4 non-painful ones, and the rest are mostly painful. So there's a big connection in this group of disorders between pain and the autonomic nervous system. Now, structural disorders. For neurologists only, everybody else, because we're going to localize now. So neurologists love to localize. Of course, I'm just kidding. Not about we do love to localize. I'm kidding about neurologists only. But so of course, you can't take a disorder and where you're not sure if the structure is normal or abnormal in the system you're studying and localize it, because you don't even know if there's an abnormality. But in a structural disorder, of course, you can specifically localize and try to figure out where the problem is. So neurologists will divide the localization into central and peripheral nervous system disorders, and also, or combined. And the prognosis and treatment are very different. So if you think about central nervous system disorders, what can involve the central nervous system? Kind of a descending order: multiple system atrophy, Parkinson, Lewy body spectrum, which, by the way, is a combined disorder because Lewy bodies are found in the autonomic ganglia, strokes involving brainstem integrators, and myelopathies, traumatic and demyelinating. So those would be central disorders. And then peripheral nervous system disorders, again descending. You could have something involving the ganglia, like pure autonomic failure, and we have one person with that this afternoon. An autoimmune autonomic ganglionopathy, or an autonomic neuropathy. Okay, so what do you think? Is our patient who came in, our 78-year-old man, is he having a peripheral disorder or is he having a central disorder? Yeah, central, right? He's got memory loss, he's got gait changes, so that together tells you it's probably central. But without that, you really couldn't be sure. He's got orthostatic hypotension, he's got bladder and bowel. It could really go either way. Okay, so likely central for the reasons we talked about. He doesn't have any peripheral complaints or findings. And so let's think about what types of diagnoses he might have. He might have multiple system atrophy, Sjogren's syndrome. He might have Parkinson's with some diffuse Lewy body involvement of cortex and autonomic centers. Or he could have a multi-infarct process that looks like Parkinson's. So let's just talk about come back to those. So I'm taking a little tour on the peripheral and coming back to the central. So now, of course, autonomic nervous system can be involved in the peripheral nerves as well. And so we talk a lot about small fiber sensory neuropathy. And so you've heard about this term bandied about. They've got a small fiber neuropathy. And what does that mean? And so really both autonomic fibers and pain fibers are small fibers. So a small fiber neuropathy could involve either or both. And I think the best way to think about this is to divide in your mind's eye, is it involving both or is it involving just one? So if you have a small fiber sensory neuropathy, purely, you'll have spontaneous pain, maybe some loss of pin or temperature sensation. You may not be able to sense your end organs. But if you have an autonomic fiber, which is a efferent motor problem, then you'll wind up with some loss of the ability to maintain blood pressure, like orthostatic hypotension, difficulty with regulation of heart rates if you have a parasympathetic problem, and you may even have something affecting the gut if you involve the enteric system. I just put this up as a way to sort of debunk the whole small fiber thing. So think of it not as, well, as tingling. Think of it more as, do they have the sensory side, do they have the motor side, or do they have both? And then if we think about what causes that, small fiber neuropathy in the United States is diabetes until proven otherwise. And that includes glucose intolerance. When I say diabetes, I mean just a little bit of sugar intolerance, and that can be associated with a small fiber neuropathy. What is it doing there? I'm not sure. It's clearly an association. You don't have enough sugar intolerance to actually cause the diabetes, but there must be some sort of immune association between the two. And then the next largest category would be Sjogren's, and that would be about another 10 or 20%. Now, worldwide, it's probably more like, Gisela, you can correct me, but I'm thinking trypanosoma cruzi or leprosy would probably be the worldwide cause of small fiber neuropathy. But in the United States, We don't have those problems. We have the problems that we're overfed. And so Sjogrens, and then you've got a slew of others: post-infectious, paraneoplastic, monoclonal protein associated, B12 deficiency can produce a large fiber and a small fiber disorder. And then you've got a slew of others that are more rare. So I just want to, for completeness sake, give you that picture also of what's happening. And we'll come back now to the central disorders. So we're going to cover Parkinsonian disorders now. And I'm going to talk a little bit about Parkinson's disease, a little bit about multiple system atrophy, and a little bit about multi-infarct Parkinson's. So the first thing to realize is that these disorders have very, very different prevalences. So the odds of seeing a patient who has multiple system atrophy in your office on a routine basis are very, very unlikely compared to Parkinson's disease. Multiple system atrophy, 4.4 per 100,000. Parkinson's disease, not quite 4.4 per 100, but it's almost there. So it's 1,000 times, just about 1,000 times different frequency between Parkinson's disease and multiple system atrophy. Now, multiple system atrophy has two forms: a form that kind of looks like Parkinson's disease and a form that looks more ataxic, like a cerebellar process. And Parkinson's disease, of course, has only one form, which is the Parkinsonian form. And vascular Parkinson's is somewhere between Parkinson's disease and multiple system atrophy, but probably closer to Parkinson's in terms of its it's 250 times more common than multiple system atrophy. So multiple system atrophy is the least common of these disorders. So let's refresh our case and think about what this person might have. So 78-year-old man with falls, freezes, nearly falls while walking, and his blood pressure. So what do you think? Do you think he's got Parkinson's disease, vascular Parkinson's, or multiple system atrophy? Sorry? Vascular? Do I hear higher? Do I hear Parkinson's? So the odds are, like, he could have multiple. So how do you define these disorders? Multiple system atrophy, or Parkinson's plus, Parkinson's diffuse Lewy body disease complex. That is Parkinson's plus severe autonomic dysfunction. So that constellation defines both of those entities clinically. So the question is, which does he have? And let's just look at the odds being in your office. So this is a sort of a little bit of an epidemiologic study. And if you look, these are patients. Over here are all the patients who had orthostatic hypotension. This group had Parkinson's disease. This group had multiple system atrophy. And this group had progressive supranuclear palsy that we will not talk about any further. They really don't have any orthostatic issues. So if you look at the odds of having orthostatic hypotension if you have multiple system atrophy, well, clearly it's high. But if you look at the odds of this person in your office having multiple system atrophy, it's much more likely to be Parkinson's disease, even though the minority of patients with Parkinson's disease have such severe orthostasis, simply because the odds of having Parkinson's is so much higher, and the prevalence of Parkinson's is so much higher. So this is just a little bit of history about multiple system atrophy. There were sort of two disorders discovered separately. Olivopontocerebellar atrophy, which winds up being the cerebellar type, and striatonigral degeneration. And then the Shy and Drager in '60 coined the Shy-Drager syndrome. And then in '69, Graham and Oppenheimer brought these into a single entity, and that was confirmed in '89 because they have the exact same pathologic finding, which is the glial cytoplasmic inclusion found in oligodendroglia. This didn't come out very well, but that's an example of one down below. So, and then on MRI, there's a couple findings you can see in multiple system atrophy. One is the cross-bun sign, which is shown on the right side, and you can see the pons has become atrophied, the cerebellum has become somewhat atrophied, and you have a little bit of a, looks like sort of a bun sitting on top across because of the atrophy has been so severe. And on the other finding, so that's right in here, and the other finding is this finding right here where you can see putaminal deposits and putaminal changes here, We see the white matter coming through the putamen, and that's the other major finding you can see in multiple system atrophy. So there have been multiple treatment trials for MSA. I don't think I'll go through these because I think the point of this is really to get to management of autonomic disorders. Really nothing has worked so far. And there's really, so there's a bunch of trials that we're going to go through tomorrow with the patients, Saturday, what's going on right now. But a very large number of attempts have revealed essentially nothing. Okay, and then can you distinguish, so how do you distinguish, let's say you're having trouble figuring out if somebody has multiple system atrophy or somebody has Parkinson's disease. Are there tests you can do? Well, yes and no. So autonomic testing over time declines pretty rapidly because multiple system atrophy declines pretty rapidly. So you can see changes. But if you take one snapshot in time of somebody with multiple system atrophy versus somebody with Parkinson's disease, and if they have, the Parkinson's disease person has very severe autonomic dysfunction, you will not be able to distinguish the two. It's very, very hard to tell them apart. Now, it's been published that the QSART is more involved in Parkinson's disease. That's probably true in a population, but in any individual, I think it's pretty hard. And this is the thermoregulatory sweat test we saw in our patients with multiple system atrophy versus PD, and they're really very, very similar. So the Mayo group, on the other hand, felt that you can see a difference, but to be fair, in this group, they did not really pair up the severity of Parkinson's autonomic findings with multiple system atrophy. So I think the jury's out at this point as to whether you can tell or not, but it's very hard. I just want to take a moment to talk about the effects. So we have a lot of patients who have Parkinson's disease or some patients with multiple system atrophy who are on dopamine. And I don't know, how many in the room have heard, be careful about using Ldopa because it'll worsen pressure? Just a show of hands. 1, 2, that's it? Just 2 people in this room? 3? Okay. So it's something that's said. Be careful about using Ldopa because it could lower blood pressure. So the bottom line is that in careful studies that have looked at this, Ldopa really does not make a significant difference in blood pressure. So if somebody needs Ldopa, if somebody needs Sinemet, just go ahead and use it and just monitor their blood pressure, tell them about the risk, but don't withhold Sinemet or any other dopaminergic agent from somebody with Parkinson's if you think it's indicated for the motor, for what they have motor. Vascular Parkinson's, very easy. There it is. Not one single article on dysautonomia and vascular Parkinson's. So the jury's out. Do they get orthostatic symptoms or not? We don't know. All right, so let's come back to our guy, and now let's think about how we evaluate and how we manage. So we think he may have Parkinson's disease, he may have multiple system atrophy. From a prognosis perspective, that's very important to know, but from a management perspective, you're going to manage him pretty much the same way. So here is his autonomic testing. So remember when Deb showed you the deep breathing response? So that's measuring parasympathetic function. His deep breathing response is 3, with normal for his age being 8. His Valsalva ratio, which measures kind of a big view of the whole system, sympathetic, parasympathetic. His ratio, which is the heart rates at the best time when he's going fastest and the heart rate is lowest, is 1.06, which is low. And let me show you his tilt table test, which is here, and you can see that when you tilt him up, here's his baseline blood pressure here, about 140/80. Then he drops pretty dramatically, which is what Julian was showing earlier with the early orthostasis, but it lasts longer than what Julian showed you. This lasts probably about 5 or 6 minutes. Then he finally comes back up, fluctuates, stays for a while. Heart rate does virtually nothing, as we saw in the emergency room. Then he starts dropping again. It looks like he's about to go out, so he's tilted back and his blood pressure comes back. So this is not horrendous orthostatic hypotension, but it's a fluctuating pressure with periods of orthostasis. And if we did his thermoregulatory sweat test, this stick figure shows that he's got kind of a, that's not sweating in the legs, and he's sweating on the upper body. And so that's a funny pattern, sort of a quadrantic pattern. You can see that either in multiple system atrophy or in Parkinson's disease. And so his testing confirms that it's structural, not functional, because remember we said the cardiovascular reflexes should be abnormal. He's got moderately severe autonomic failure. His sweat test looks like combined. Looks like he's got a cutoff, and then he's also got some loss in the feet. And so it's compatible with Parkinson's, but his B12 wind up being very, very low. So I want to emphasize that when you have somebody with severe orthostatic hypotension, you should be checking B12. His B12 is very low. He got better for a little while when we replaced it, then he got worse again because his Parkinson's took over. Okay, so I want to focus now on how we would manage his, how we manage his issues. So his chief complaints are fall. And remember that we only elicited autonomic findings by doing the review systems and by doing his orthostatic pressures. But I think when I'm going to, in general, when you think about somebody who comes in with a fall and you don't know that their blood pressure drops, you're going to think about all kinds of systems. You're going to think about, well, maybe they're not feeling the floor. Maybe they've got a cerebellar problem. Maybe they've got visual issues, some sensory system issues. So any one of these could fail, but my point is that if any one of these is failing and then on top of that they drop their blood pressure, guess what's going to fail first? Whatever's already failing is now going to be further compromised. Because, yep?
Just a question. So were his falls syncopal or non-syncopal? Or syncopal / pre-syncopal? I mean, did he get lightheaded and faint and then fall?
We had no lightheadedness. Well, he was freezing on his examination, so he could be freezing and falling, but his blood pressure was dropping dramatically. I assumed that it was a combination. But he had no lightheadedness at all. But then again, on tilt table, he dropped his pressure and had no lightheadedness. He was fine. So my point is that it's very hard to do something about loss of proprioception. Maybe you can replace the B12, but it's, once you're missing something, it's hard to get it back. But it's not that hard to get the blood pressure up. So my point is when you're getting the blood pressure up, you're not just getting the blood pressure up. You're actually also providing a little bit more oxygen, a little bit more nutrition to the part of the system that's failing. And that's something you can do easily. So that's where I'm coming out with this really, rule of thumb for myself at least, that just because somebody has motor or sensory explanations for their falls, you still should check an orthostatic pressure. You still should check an orthostatic pressure. Because if you find that, then you can give them something, whereas the other explanations most of the time have no treatment. Okay, so now we've found that his blood pressure dropped pretty dramatically. And so how do you manage this? So we learned a lot about management of POTS this morning. And the management of orthostatic hypotension, management of POTS, have some similarities, but they also have some differences. So remember, in POTS, the fundamental issue is that there's probably some inadequate return. So the heart is not seeing enough blood coming back to it. And so it speeds up. And Julian, maybe you want to refine that explanation. Okay. And so that's the issue. Whereas in orthostatic hypotension, the problem, if you will, is on the output side of the heart, where you've got arteries that are simply not constricting. So it makes much more sense to be aggressive with alpha-1 agonist or norepinephrine type agents in orthostatic hypotension. Not that it doesn't make sense in POTS. You can do it in POTS. But you want to do it even more so in orthostatic hypotension. So the main difference for me is that in orthostatic hypotension, you're really going to be more aggressive and try to get the blood pressure up higher. So salt loading, you may require 3 to 15 grams per day, and do it in divided doses, so 2 grams in the morning, 2 grams in the afternoon. If they have hypertension also, you're going to be limited. So if they have, especially if they have standing hypertension. If they have supine hypertension, then you don't need to worry about it. Just when they take the salt, then they shouldn't lie down until they're done. The second thing is you want to elevate the head of the bed. Why do you want to do that? Because it reduces nocturnal microgravity. So have you ever seen the pictures of astronauts when they come back from space and they're always in their suits? Do you know why they're in their suits? They're not in their suits just because they look good. They're in their suits because after 2 days out in space, basically you have no ability to maintain blood pressure. So, and that's simply a property of really healthy, athletic human beings. So lying flat is not exactly being in outer space. But if you're lying flat continuously, and if you lie flat for 8 hours, as you do overnight, basically you unload the system. And during that time, when you're lying flat, you're a little bit like an astronaut in outer space. And so in the morning, you get rid of a lot of, during the night and in the morning, you get rid of a lot of fluid, and your system is not quite as tuned. And so if you put the head of the bed up by about just as much as they can tolerate without winding up as a clump at the bottom, and really it's usually as much as their spouse can tolerate, then you manage to maintain much more fluid in the system, and their vascular system is much more toned. So that's a very important one and very easy to do. Then you can use high pressure hose with an abdominal binder, which can gain you about 30 millimeters of mercury. And then you can use exercise training. And then you can get them conditioned with water jogging. And notice that I have not used a single drug. And this will take care, in my experience, of about 50 to 60% of patients with significant orthostatic hypotension. If you do this well, you don't need to use a single drug. And I think it's probably more effective than the drugs. I will tell you that if you don't do this, the drugs will not be effective. So if you don't load somebody with salt and get their volume up, there's nothing for Mitogen to work on. There's nothing for RoxyDopa to work on. So it will not work.
Can I just throw in one little tidbit?
No.
I'm just asking if you guys, I'm going to do it. You know, people hate joke compression stockings. They hate them, especially old folks. And I learned something from Bob Feely, which is snug biker shorts are a lot more tolerable. So those kind of lycra, those kind of snug biker, and they go from ear to ear.
But they push the blood down.
Well, no, it's just an option. The Jobs would be better.
Yeah.
People don't put them on.
Yeah. I think it depends how much difference it makes in their daily life whether they put them on or not. And I agree, they will not put them on in the summer. But a lot of my patients use them in the winter. Okay, so this is the effect. This is kind of points out the effect of these non-pharmacologic measures in patients who pass out, and the change in plasma volume. So this is HUS, stands for elevating the head of the bed, and you can see some people get a pretty significant increase in plasma volume. And this is time to syncope. So you can see some people extend their time to syncope significantly. If you look at salt loading increases volume significantly as well. Exercise, which is probably the most important thing for everybody, just as in the functional group, does as well. And placebo, we should use because this person got an incredible effect, but most of the others did not. So, so I really emphasize these. They're very, very important to use. Okay, then additional things you can do frequent small meals. You can do self-tilt exercises. So it's been shown, for many years, people were doing tilts and then doing more tilts, and it didn't work. It was not reproducible. So they'd pass out once, and then they wouldn't pass out the next time. And then this cardiologist named Hector in Belgium figured out that it's actually a consistent phenomenon. And the more you tilt them, the better they do. And that's because you're basically conditioning the system. So if you lean up against the wall once or twice a day for about 5 or 10 minutes, you condition your system. It's really an enhanced version of the reducing microgravity at night. Now you're enhancing vascular, when I explain it to the patients, I say we're doing vascular calisthenics. We're just making your vessels do more work. Physical counter maneuvers, a lot of these have been described. And then water drinking is a surprise. It's a big surprise. Water drinking is a very helpful. So this is the paper looking at tilt training, and it works long term. This is a Japanese study of 24 patients, and they go on average from about 8 plus or minus 5 minutes of being able to stand. And over time, with orthostatic training, which is standing up against the wall twice a day, at 15 days, they're all able to stand 30 minutes. Now, this is for patients with syncope, not patients with orthostatic hypotension. But there's no reason why the same concept wouldn't work. I just don't think you're going to get the same impact. And these are various counter maneuvers. You saw the party maneuver that Julian said. Why did you say that they have to have their hands in front of them for the party maneuver? No. You said the party maneuver has to. Oh, okay, to hold the cocktail. That's right. Okay. Okay. And then you've got the squat. You've got the single step on the stool, and you've got the sit. And these are all helpful to elevate blood pressure. And this is a study in which they actually looked at this a little bit more rigorously. This is from Wouter-Wieling and the Dutch group who've really studied this carefully. And this person is on a tilt table. They're getting ready to pass out. And then they come back up. When they do their leg cross, blood pressure comes back up. They're going to pass out. They do the leg cross, blood pressure comes back up. And then they step off. And then they do a leg cross off the table, same thing. Same thing with the squats. Same thing with the squats. And finally, this person is allowed to sit down. So these maneuvers are very, very helpful. Now, water drinking. Water drinking is a surprising thing. It turns out that water, just hypoosmolar water, if you just take a glass of water, 16 ounces, at the bedside, without salt, you increase blood pressure in patients who have difficulty maintaining blood pressure by an enormous amount. So this is a group of patients with multiple system atrophy. This comes from the Vanderbilt group, and this particular publication is from Jens Jordan when he was there. There we go. So here is the water, this is time 0, the water's taken in. And look at this rise in systolic pressure lasting an hour or beyond. And for pure autonomic failure, you see the same thing. So this is a little known trick, but anybody can use it. And absolutely no reason you cannot use it. So you put the water, and of course this is perfect, because how long does it take for medications to start working? Half an hour to an hour. So you've got that window of opportunity where there's no medication on board. You give them the water, drink it, they get better. There's a few patients in the room. Do you use this trick? Yep. Do you use it? No? Okay.
We give it to the patients with POTS, but in the theory it shouldn't help in the slightest, because we don't need to raise the blood pressure in the POTS patients.
Well, no, I don't know that we know that.
You're right, but there still may be issues with vasoconstriction that this is addressing.
Yeah.
I just don't know enough about it.
And I don't think we've tried it.
I was thinking we should do it.
It would be a neat study to just see how patients with POTS do with this. Paula, have you had any experience with that?
Well, the group that does well with the water drug, the water doping is the one that normally you give them Mitogen. So same concept.
Yes.
The one that basically, probably if they didn't have the tachycardia would be hypotensive. So,
Gotcha. So you're trying just to avoid them.
right.
No, Paula, do you know if somebody has done it?
What, the study?
The study with water load and POTS?
Not that I can think of.
No, just curiosity.
And then, of course, everything is not exactly as it appears. So salt supplementation for years, I just assumed that it expands volume, right? You take salt, it expands volume. It turns out that it's got a major impact on Dr. Stewart's favorite molecule, which is nitric oxide, and it reduces endothelial nitric oxide synthase activity. If you take a 5 millimolar increase, will reduce it 25%, and a 10 millimolar is 45%. So that's a significant reduction in nitric oxide activity, so your vessels are less dilated, and that's how salt actually works. So I start with 2 grams twice a day, and I just titrate up or down based on response. Okay, then we have a few medications we can use. We have Mitogen, which is best used for if you have a true arterial problem. But as Paula just pointed out, if you've got a situation in postural tachycardia where you're up against a wall, the blood pressure seems to be sort of borderline dropping. Anytime you think blood pressure is dropping, Mitogen should be helpful. It's an alpha-1 agonist, so it's a substitute for norepinephrine, and it'll increase blood pressure significantly. It's nice in that it only lasts 4 hours, doesn't cross into the brain, and so you can give it to somebody who's very active at 8 a.m., noon, and 4 p.m., or somebody may want to take a nap in the afternoon. You may after lunch, so you give it at 8 a.m., and then it works till noon. They eat their lunch at 1, they take a nap, and you give it again at 3 p.m., and then they have it for the rest of the evening, and then they can be down for a couple hours. They really shouldn't lie supine once they've taken it because the blood pressure does rise significantly. Okay, fludrocortisone is another agent that's very helpful, and I'm sure all of you have seen it or prescribed it at some point. I really just want to point out one thing, which is that at high dose, which is usually about 0.2 milligrams per day or more, is primarily a mineralocorticoid. But at low dose, it activates alpha-1 receptors. So if you want to use that, and I use in POTS patients, I use it a half a tablet every other day or half a tablet every day, just to get that sensitization of the alpha receptors. And then if you add Mitogen, you've got a great marriage. You've got the alpha-1 agonist, alpha-1 sensitization, and now it all works better. And if you add salt and fluid to that, then you get a really good combination. Pyridostigmine, that was Paula's work with Wolfgang Singer. And pyridostigmine was used for years in myasthenia gravis. And what it is, mestinon. It basically just facilitates neurotransmission. But the point is, it facilitates neurotransmission across all ganglia, right? So it facilitates neurotransmission across neuromuscular ganglia. It also facilitates neurotransmission across sympathetic ganglia. So why not give it a try? And so it's pretty effective. It increases blood pressure. It doesn't have the same bang as Mitogen, but it's pretty effective. The big advantage is it does not increase supine blood pressure very much. So if you really have somebody who's got very high pressures and they're supine or high pressures when they're even when they're sitting, and yet you need to boost their pressure when they're standing, this is the right person to use it in. And this picture shows the systolic blood pressure, and this is in the supine. You can see there's very little change, and standing, you can see that there's significant change. And it correlates pretty well with symptom improvements. Okay, and then there's a medication that's been about to be on the market for about 3 years. And this is a medication called RoxyDopa, which is Ldops. And this is very, very similar to Ldopa, except that rather than facilitating dopamine production, it facilitates norepinephrine production. It's been in use in Japan for about 22 years. It's an excellent agent. Many of us in this room have been involved in trials for this drug. And, but there's some statistical issues with the clinical trials, so the FDA said, no, we're not going to do it. Then many patients and organizations wrote in and said, look, there aren't drugs for orthostatic pressure. This is a great drug. You've got to turn this around. The FDA did turn around, surprisingly, and so it looks like there may be approval for this in the next 3 to 6 months. I participated in the trial, and I really liked it. And it hopefully will be on the market soon. You use it just as you would use Mitogen. It increases the amount of norepinephrine in the system and activates the alpha receptors. Other drugs you can use, clonidine, indomethacin gives you actually better volume expansion than fludrocortisone does. If the person's anemic, erythropoietin can be helpful. I just want to spend a moment on supine hypertension because it is, looks like, okay, I got 2 more minutes. Supine hypertension because it's a problem we really do run into. How many have seen in this room patients who have orthostatic hypotension, and supine hypertension. So several, yeah. Okay. And that's a conundrum. And so the first question is, where does the supine hypertension come from? Is it just the fact that you've loaded them up with salt, or they have self-loaded with salt, and this has caused a lot of accumulation of fluid, or is there something else going on? And the answer, it turns out, is there's something else is going on. So this is a study in which this is again the Vanderbilt group. They gave yohimbine, and yohimbine is a alpha-2 receptor blocker, and so it blocks. What it does is it increases the amount of norepinephrine in the cleft if norepinephrine is there. So if you have no norepinephrine in the cleft, yohimbine will do nothing. So in order for yohimbine to be active, there has to be norepinephrine in the cleft. So they asked the question, if we give this agent to somebody who's supine, will the blood pressure increase? Meaning there's norepinephrine being secreted. Now remember, when you're lying flat, a normal person lying flat has no norepinephrine secreting. So you only secrete norepinephrine in a vascular neuron's cleft if you are standing up. So when you stand, you activate your sympathetics. When you're lying flat, there's no. So in a normal control, you should have no increase in blood pressure if you give somebody yohimbine. And notice that in a subgroup of these patients, the yohimbine produced a dramatic increase in blood pressure while the patients are supine. Whereas in pure autonomic failure, it did not. So what's the conclusion? The conclusion is that not only do patients with multiple system atrophy and probably Parkinson's disease not raise their blood pressure adequately when they're standing, they actually raise it excessively when they're lying flat. So it's a whole screw up. The whole thing is screw up. The whole thing is backwards. So when you're treating supine hypertension, you actually have to be pretty aggressive. You actually have to lower the blood pressure when they're supine and increase the blood pressure when they're standing. And you have to use both. So you combine antihypertensives with pressors. And I use a lot of these. I use beta blockers because beta blockers increase venous return. And I use angiotensin blockers because they're pretty quick acting, especially something like captopril, and I use short-acting calcium channel blockers for antihypertensives. And then I add the pressors during the day. Okay, and then just a couple things about bladder. So that's blood pressure. A couple things about bladder. Of course, loss of control is due to degeneration of the autonomic systems that control the bladder, and urgency is due to changes in spinal circuits and the bladder nerves themselves. So how do you manage it? You want to evaluate for large prostates in men, but you want to be very careful. I'm talking about people with Parkinson's disease or multiple system atrophy, but you want to be very, very careful not to just go in to an operation without having a careful conversation with the urologist and the neurologist to make sure the prostate is really a problem. You can use the usual medications, ditropan, detrol, and vesicare, but with retention, you've got a big issue because alpha blockers are going to counter the alpha agonists. And you also have to be careful that when you give somebody either RoxyDopa or Mitogen, you don't actually produce urinary retention because the alpha agonist is going to not only tighten the vessels, it's going to tighten the sphincter. So you really have to watch out for that. So you often wind up with doing self-catheterization. And the one point I want to make about self-catheterization is that it's not an all or none decision. You want to keep bladder function as long as you can. So it makes sense perhaps you do a catheterization first thing in the morning after the night's urine has accumulated. You do a catheterization before you go to sleep so you don't accumulate. And then during the day, you just go to the bathroom. You don't catheterize. And you want to, as long as possible, not put in an indwelling catheter because of the risk of urinary tract infection, which can be very serious in these patients. Constipation. This, I believe, is the last slide. Constipation. I generally use polyethylene glycol as my first-line treatments, and I just titrate the number of tablespoons to what's needed to get, and I learned all this from my wife, gastroenterologist, to keep the bowel moving. You can add a glycerol suppository. You can also add clonidine. Yep?
I just wanted to make a comment because you use pyridostigmine, which also will help you with the constipation.
Yes, it might.
And so when you're trying to control the blood pressure, if you add the
Pyrostigmine, you can do both. And then you can do a clean out, a quarterly clean outs if you have recurrent obstipation, using 1 dose of Dulcolax, 6 doses of Miralax, and 1 dose of Dulcolax. Start in the morning and stay close to the toilet. Don't do this before you go to bed. Diarrhea, don't be fooled. Diarrhea can be from constipation. You can have overflow, and most of the time it actually is in this group of patients. Okay, thank you so much, and that's the end of the lecture.